Welcome to this session, which is called DAPT Challenges in Complex Clinical Scenarios. My name is Marco Valgimigli, and I have the privilege to co-chair this session with Peter Smits, who just entered the room. Peter, you need to be mic'd up, otherwise you will not be able to speak to us. Let me show you first my conflict of interest, which I promise will not play any role during the session. And let me walk you quickly through the agenda, just to make the point clear that we will have a completely case-based discussion. That's what we want to have, a practical discussion on real and challenging cases. But importantly, I would like to make the point clear that also we have 4 fantastic operators which will share with us challenging cases as well as challenging decision not, and we would really love your input in respect to those. I don't want to take too much time because I'm sure there will be a huge amount of discussion, and I foresee a lot of interactivity from your side, which we are looking forward. Let me just walk you through the common themes I think we will have in this session. We'll speak about ischemic and bleeding risk, as you may imagine, and we will be speaking about predictable versus non-predictable ischemic and bleeding risk. And I guess since we will try to make our best to put our challenging clinical cases into the context of how should we protect them from prevention of ischemic and bleeding events, I think we will end up speaking about modifiable versus non-modifiable risks. And let me clarify this point. If a given patient is at high risk because we predict that patient to be as such for a specific type of group of events, such as bleeding recurrences or ischemic recurrences, this does not necessarily mean that we have to change our treatment paradigms based on that risk, unless we have a clear and I would say unquestionable evidence that by doing so we can actually interfere with that risk, meaning we can modify that risk. So again, I don't want to steal the time from the discussion. Just to close, 2 quickly housekeeping remarks. This session is for you and for us. Don't be shy, speak up. We will have 2 roving microphones. We will have actually still microphone. Time to react is not active during this session, but we would really love to have your input, so please try to speak and interact with us as much as possible. And then we will try to be really on time, actually a little bit earlier than that, because all the faculty is engaged in an important activity at the end of this session, which will request that we will be finishing up the session some minutes before actually the predicted time. So with that said, let me formally welcome my co-chairperson, Peter Smits. Please come on the stage. And also let me call upon the first speaker, who is Bernard Chevalier, who is actually speaking about case number 1, many stents, an emergency, and now what? Bernard? I already launched the slide.
Thank you, Marco. This is my disclosure. I will show you the case of this gentleman. He has a risk factor, as you can see, dyslipidemia treated with statin and hypertension treated with ACE inhibitors. So he had no significant comorbidity, as you can see. There is nothing really special in terms of lab values. Is very symptomatic with a CCS3 angina since 3 months, and confirmed by Italian scintigraphy showing anterior and septal ischemia with slight decrease of EF at stress. And for this reason, he was referred for diagnostic angiography and revascularization. We can see that we have some intermediate disease on the distal left main, proximal LED lesion, very distal LED lesion. Nothing special on the circ, and 2 lesions on the right, one at the mid-segment, one just before the crux. We do FFR from left main to circ to decide if we need to consider the left main as a criteria to make a different decision in terms of revascularization. This FFR was negative, 0.85. And we calculate the syntaxor not taking into account this left main lesion, which is 15, and you can see that we have almost equipoise for syntax 2, 29 for PCI, and 30.5 for cabbage. It was decided with the patient to go to the PCI. We decided to enroll in the Discovery 1 to 3 trial. We'll show you briefly in the next slide what is the Discovery 1 to 3. Receive a loading dose of clopidogrel aspirin, and from the start we decided to have a post-PCI drug regimen, which is very simple, and based in terms of DAPT on the clopidogrel and aspirin association for 6 months. Discovery 1 to 3 was a trial performed in 60 patients with multivessel disease, and the target is to obtain an evaluation of the strut coverage at 1 month, 2 months, and 3 months after implantation, meaning that we treat the first vessel at baseline, and we do OFDI. At 1 month, we do the second vessel, and we perform OFDI of the first vessel. We have 1 month follow-up of the strut coverage of the first stent. At 3 months, we do angiographic control with OFDI in all vessels, meaning that we have 1 month follow-up and 3 months follow-up for the first lesion of the first vessel treated, and we have 2 months follow-up for the second vessel treated. So in total, in the same patient, not the same vessel, but in the same patient using the same stent, same type of stent, we have 1 month, 2 months, and 3 months evaluation. This is the result at the stage. You can see at the initial treatment. LED PCI, we start first with LED. We put a 3024 Ultimaster with some high pressure post-dilatation because it was calcified. And 1 month later, we address the 2 lesions on the right, the mid part and the distal part, with Predil using 3.0 balloon. After we implant a 3.0 stent in the distal part and a 3.5 in the proximal part with post-dilatation in both stents. Unfortunately, 4 days after this PCI, on 36 days after the first intervention, the patient has a significant hematemesis. As you can see, a significant drop of hemoglobin. It's by definition bark-free bleeding event. He was hemodynamically stable, and he received 2 packs of transfusion. He was put on IV PPI and underwent an emergent gastroscopy showing a gastric ulcer with arterial bleeding treated with electrocoagulation. Despite this treatment, 2 days later, he has a controlled gastroscopy with showing a persistent mild bleeding, and the gastroenterologist came to us saying we have to stop the DAPT. So at this point, what we should answer? Stop one platelet, which one? Or do we base that on platelet testing? We do stop both treatment, or decide to base our decision of the OFDI we have performed during the procedure, or try to resist to the request of the gastroenterologist.
Perfect, Ben. I think this is beautiful, the moment to be interactive with you, audience, and the thing that we'd like to do is to poll with you and to ask, what would you do in this specific case? We have 4 questions, and by raising hands, it's going to be interesting to see what would you do in this clinical situation. Severe bleeding and request of stopping DAPT, 4 days post staged PCI, and 36 days post stenting of the LED, and 4 days post stenting RRCA. So, let me ask you, who would stop one of the DAPT elements? Don't be shy, it's okay. Let's say 1/3 of the audience. And which one would stop aspirin of those? Now we see much more. So I think half of the room would stop aspirin. Who would stop clopidogrel? Nobody. Okay, good, aspirin. So let's bring this discussion to the panel. What would our panelists would do?
Well, I answered. I would stop aspirin first and evaluate if the bleeding is controlled. I will stop aspirin first and evaluate if the bleeding is stable. Otherwise, I will really think twice before stopping also clopidogrel. Another strategy that is not used but may make sense is to do a test on platelet responsiveness or clopidogrel. If by any chance you found that you have 0% inhibition, that becomes a risk to leave the patient only on clopidogrel.
Yeah, I think I will also stop aspirin, especially while in this case the bleeding is not really life-threatening, meaning the patient has been treated for the gastric ulcer, he just had a control 2 days later showing still mild bleeding. So I think the risk of bleeding at this specific moment will not probably justify to stop everything and to have the risk of stent thrombosis 4 days after PCI, but it can be discussed, of course.
I would be a little bit more aggressive. I would not stop aspirin. I would not stop clopidogrel. I would say to the gastroenterologist, go home, have a nice drink. And I would continue my IV infusion of PPIs. I would put the patient on high surveillance, so in my unit. And yeah, basically I would continue.
Okay, let's continue. Can we have the slide back? And because we have, so nobody would stop DAPT altogether. Huh? I think that's a consensus over here.
You did not ask that question,
Yeah,
so
yeah.
let's try. Who would stop DAPT all of a sudden?
All, both? No, nobody. Yeah, okay. Okay, can we have the slides back on? Okay. Is somebody within the audience would would perform OFDI in order to see whether they have enough strut coverage before you stop one of the elements of DAPT? Hence? So OFDI is not an option. Okay, let's continue with the case.
Yeah. So as we have this OFDI, because we did the case 4 days before the second stage of the second step of this revascularization, we have in fact over 1 month follow-up of the LED lesion. You can see the run on the left part of the slide, on the carpet view on the right part. So we can see that we have a relatively good coverage, 83% by the core lab analysis. We have some under deployment at the proximal part due to the calcification, but no malapposition. And if we go to what we did just 4 days before on the RCA, we can see that the first baseline check was showing a proximal malposition in the distal lesion, and it was also showing a distal malposition in the proximal stent. This is the reason why we perform a post-dilatation just after these initial runs. We put a 4 mm balloon 4 days before in these 2 lesions, and we obtained a good result without a significant malposition in both lesions of the RC ray. So having done that, considering the question we asked, we decided by team to stop the aspirin, as suggested by many of you. We continue high-dose PPI, and the gastroenterologist was okay to perform a 4 weeks control with no more bleeding, of course, and to make biopsy because it was a gastric location of the ulcer. And we decided to maintain clopidogrel alone until the 3-month control planned by the trial. And at 3 months, we can see on the left side the coverage we obtain in the LED. On the right side, here we are in the left main, you can see that we have 2 lesions in the same run. Distal lesion with just proximal to the crux, and it's going very soon to see the mid part of the RCA, which is also showing a good coverage. Just to remind you, the Discovery 123 trial has shown a very nice strut coverage rate. As we can see, at 1 month, almost 86% of the struts are covered, 89% at 2 months, and 95.7% at 3 months. So the next question is about the long-term prescription in this patient. He received ACE inhibitors and rosuvastatin for treatment of the dyslipidemia. Do we continue clopidogrel over 3 months? Do we continue PPI?
So let me ask a question. If you decide to stop aspirin, why not test the responsiveness of clopidogrel? You leave the thrombosis protection 100% under the care of clopidogrel. I know that you're going to answer to me that there are no randomized studies on these issues, but this is a very unique situation. Don't you think it may make sense to do a study, a simple responsiveness of clopidogrel, just to know in which ground are you moving?
I don't know what the panel thinks. In fact, it's our practice when we stop aspirin to check the sensitivity to clopidogrel using a PFA 100, but we know that it's out of the guideline.
And in fact, I believe that in clinical practice, not many people actually have the capability of do functional platelet testing. Let's poll this, for instance. How many of you in the audience do functional platelet testing in your cath lab? So that's really a minority, 3 people out of the 50 people that react. I think that's also a kind of clinical scenario that we are dealing with, that not everybody has the capability of doing it.
Yeah, we don't do it, but we have the capability in special situations.
So
in the fact that you don't do it doesn't mean that you should not do.
Let me tackle that, Antonio, because I tend to agree with you. So it's true, there is lack of evidence with this specific scenario, but the guidelines are actually not in disfavor of that approach. The guidelines are having a 2B/C level of recommendation in this specific case. We would read as you may want to test responsiveness to clopidogrel in this peculiar case. The guidelines are giving a class 3 recommendation to routine platelet function testing, but not to selected platelet function testing, such as the case we are discussing here. There is no evidence. If I were the patient, I would pretty much like that the doctor is actually checking responsiveness to clopidogrel in this specific case.
Marco, if I can just, I agree that it completely makes sense, but again, very few of us can do it. But we also know that the response to clopidogrel, when we test it, will have a clear impact on clinical outcome for the early post-PCI timing. But when we've checked stable patient or even patient undergoing elective PCI, the clear impact on the test, on the clinical outcome is much weaker. So I think the impact is early in high-risk patient, but at this stage in stable patient for secondary prevention, I'm not sure there is so big impact.
Well, think about having a stent implanted 4 days before and actually being left after 4 days with no antiplatelet therapy. So aspirin is
No, here
off.
we are 3 months post-PCI, so it's a little bit...
The first one.
The first time, yeah.
But the second PCI was actually 4 days before. So you have a stent being implanted 4 days before, aspirin is dropped, half-life will be such that you still have 2-3 days of coverage. If you are not responding to clopidogrel, you are basically have no antiplatelet therapy whatsoever. I'm not going to say the risk of stent thrombosis is 100% because it's not 100%, but at least 30-40%.
Yeah. Just don't want that 99% of the people in the room who are not using these tests, they are not feeling guilty when they will leave the session.
I'm not using that either, but if you ask my opinion, that's what I think. Bernard, probably you want to go ahead and conclude the case?
No, I want to get the answer about clopidogrel. What do you do with clopidogrel? You continue, you stop? We are 3 months after implantation.
So what I would do, I would of course continue clopidogrel.
Okay.
This patient actually was a survivor after having stopped aspirin, so I would probably continue clopidogrel monotherapy at this stage.
Okay.
Because even if this patient has received local treatment, the risk of recurrent GI bleeding is probably not that small. And since we are commenting in that direction, let me ask you the question, was this patient on PPI since the very index PCI,
No.
or that was only added afterwards?
No, PPI was added at the time of bleeding event, but he was not on PPI. The case was done 4 years ago, before the new guidelines saying that you should add PPI as a recommendation on top of DAPT.
You know, I think you should definitely continue clopidogrel because patients with high bleeding risk are in general more exposed to thrombosis. And if by any chance, even unrelated to clopidogrel, this patient has a second bleeding episode, during the bleeding, there are many times that you have a contemporary thrombosis, even if you are protected or not protected, because the bleeding situation is a very prothrombotic situation.
Good. I think for the sake of time, we have to continue, and according to the program, we have to give you some learning points. I think what we have learned from this case is that by the OFDI study, the 1 to 3 discovery study, that we now know that stud coverage really takes place in the majority in the first month with within the Biolumis Ultimaster stent, and that if you have a GE bleeding, most of us are likely to stop the aspirin instead of the clopidogrel. So thank you very much, Bernard. And we're going to continue with the next speaker, Pascal Franks, talking about bleeding or clotting and calculating the risk.
Thank you, Peter. I'm getting, hopefully, to my presentation, and there it comes, I hope. Yeah, there we are. And perhaps the only modifiable risk factor in this patient was myself, because I was the operator. These are my conflicts, and this is the case. So we are confronted with a rather elderly man, 84 years old, presenting around 5 hours after the onset of symptoms with the myocardial infarction, as demonstrated on the ECG. The patient has a past history of hypertension treated with ACE inhibitors in combination with a calcium antagonist, had hypercholesterolemia, diabetes mellitus, non-insulin dependent, treated with metformin, was a former smoker, had a chronic renal failure with a reduced estimated glomerular filtration ratio up to 42 mL per kilogram per 1.73 meters square, and a hemoglobin level of 10.8 and a white blood cell count of 7.2. Of course, at that moment, we were treating a patient with a myocardial infarction. It was a bifurcation lesion. We opted for a 2-stent technique in this patient. I think after the final kissing, we were ending up with a reasonable stent result. Of course, it was not only about the case and demonstrated that we could do by 2-stent technique for a bifurcation lesion, but we were thinking about what are the risk factors of this patient and how could they guide us towards the management of this particular 84 years old man. And there you have to weight, of course, 2 types of risk factors. For the one hand, you have the bleeding risks, and from the other hand, you have the thrombotic risk. And just to make your life easy, I put everything on one slide so you could read with me to the slide and to recognize that indeed the different bleeding risks scores are different, and different to some extent, but also equal to some extent. So most of the bleeding risks are weighting in the fact that the patient has already some kind of anemia or previous bleeding. They're also counting in the age of the patient, and they're counting in also the renal function. And that's more or less the common factors that are included in the different risk factors. And for the others, there are components that are going in whatever direction to establish the bleeding risk of the patient. If you look for the thrombotic risk, and here again I put it out of my pocket, 5 different thrombotic risk factors, going from the swallow risk factor over to the TIMI risk factor. And again, you will appreciate with me that the renal function is coming back, age is coming back, but then you have also the clinical presentation being the STEMI or the non-STEMI in this patient population, the blood pressure coming in, and the heart rate. So different components weighting in to the risk scores of the patient. And if you then do the calculation, you are rather surprised by the divergence of the recommendation that you might obtain out of these risk factors. So if we take the bleeding risk based on the precise DAPT that one of the chairpersons have developed based on 5 large trials, there you see that the patient is indeed at a high bleeding risk with 42 points. That's not minor. And as an estimated TIMI minor or major bleeding risk for 12 months of 4.14 and a major bleeding risk of more than 2.06. And then you can walk to the Crusade score, but please notify that Crusade score is not projecting into the time. It's only projecting into the hospital. So it's basically an in-hospital bleeding risk score, and that's quite high as to the Crusade risk score. And then you have the Paris risk score that's more to the level of the precise DAPT, and that is also recognized when you look to the estimated risk. It's around 4%, and that's the same for the precise DAPT. If you take it from the other side to the ischemic risk, again there is some variance considering the different risk scores in the prediction, but you can say that this patient had a reasonable ischemic risk. So this is what we are confronted with. We have a patient at a high bleeding risk and a reasonable ischemic risk, and I think most of the factor of the risk towards ischemia is driven by the fact that it's a bifurcation also. So indeed, as in the previous presentations, we need some help, perhaps a show of hands. So who is using a thrombotic risk score in the routine clinical practice? 1, 2, 3, 4, 5. They make my life easy because only 5. Who is using a bleeding risk score in clinical practice? Okay, that's good. Now, yeah, who's using both? It can only be less than 5, of course. Yeah, I have 1. Good. But indeed, what we saw and what we appreciated in the room is that bleeding is bad. And indeed, bleeding translates into mortality. That's something that I illustrated in a sub-analysis or in a post-hoc analysis better from the TRACER trial, where I put the different bleeding scores next to each other, going from Gusto over Bark, so that you can appreciate that they all translate into mortality. But if you want to know how much, you have to appreciate also the score. And you have to know where you are. And bleeding is, in matter of fact, as illustrated on this slide, is a composite endpoint. It has some kind of a hierarchy, and that is demonstrated in the Bark risk score that typically includes this element. Again, we were speaking about different bleeding risk scores. You have, of course, the precise DAPT score that I already illustrated where we are. And then we have the DAPT risk score, but the big difference between the two that are mentioned in the guidelines, in the recommendation of the ESC, is the precise DAPT score you can calculate at the moment of the index procedure, while the DAPT score is more or less telling you or informing you on the continuation of DAPT beyond 1 year. And that's the moment that you should calculate this risk score. So there's a difference also in the scores and how you have to deal with them or use them in your daily clinical practice. So going back to the precise DAPT score, that was pretty high in this patient. And there are 5 components in this risk score, being anemia, age, white blood cells count, that is more or less an expression of inflammation, so the disease status of the patient. You have renal function, and of course, and that's also important, the existence of a prior bleeding that was also illustrated in the previous case. So my question for you, and this patient was a patient that was included in an ongoing trial, the Master DAPT score trial. So my question to you would be, how would you treat these patients? DAPT for 12 months with clopidogrel, DAPT for 12 months with ticagrelor or clopidogrel, DAPT for 6 months with clopidogrel, 6 months with ticagrelor or clopidogrel, or 5 again DAPT for less than 6 months. So who is going for 1? Nobody for 12 months. Who's going for 12 months but with a potent, more potent DAPT? Nobody. Who's going for 6 months? Okay. Who's going for less than 6 months? Let's take it. Okay, 2 brave people for less than 6 months. So this is basically also the questions that we got, and this is how the CRF looks like from this trial. So exactly as you were pointing out, I was pointing out the same things. I choose to treat this patient. If he was randomized to the standard DAPT arm, I would randomize this patient or treat this patient with 6 months, and this was driven by the bleeding risk. I would choose not clopidogrel, but I would choose ticagrelor because of the ischemic risk in this patient. And that was what I filled out in the ECRF of this patient. If I had to go for a single antiplatelet strategy, again I was opting for ticagrelor instead of clopidogrel, for the good reasons that also Professor Colombo was pointing out, that for some patients we don't know what would happen if you would go with a single clopidogrel strategy. And again, my choice was driven by the balance between the bleeding and the ischemic risk. I cannot tell you in which arm the patient was, but I can tell you that the patient passed the 365 days of post-randomization and was without any problems. So in conclusion, I can summarize this presentation by saying that the dual antiplatelet therapy reduces indeed stent thrombosis, but that's something we all know, and ischemic risk, but put the patient at risk of bleeding. But again, that's opening an open door. The risk factors for ischemia and bleeding largely overlap, more or less 20%, and the duration of the DAPT post-stenting should be driven by the balance between the two. The precise DAPT score can inform us how to deal with it, and you all emphasized that bleeding was an important element in your consideration. So the precise DAPT score to that extent is a 5 times risk score, which can be calculated, and that's very important, at the moment of the index procedure, and provides a more or less standardized tool for prediction of out-of-hospital bleeding during DAPT treatment. And if you're not yet part of this trial, I can happily invite you to be part of the Master DAPT trial and include patients to see and learn more how we have to deal with them in the future. Thank you so much.
Thank you very much, Pascal. That was a very nice and interesting case. You were not intending to disclose to us in which arm the patient has been randomized, but in fact you did. It was randomized to a short DAPT, and you actually discontinued aspirin and left the patient on ticagrelor monotherapy. So you're telling us...
How do you know?
It was written in your slide, actually. So you're telling us that the patient is doing fine with ticagrelor monotherapy. Antonio, let me pick you on these. How would you have treated this patient first? At the time of procedure, would you agree with 2-stent bifurcation technique given this bifurcation lesion? And how would you treat this patient outside whatever study in terms of DAPT duration, taking into account what you have done in the lab, so this bifurcation stenting technique, and the predictable bleeding risk, which is not low? That's what Pascal is telling us.
But I would have given clopidogrel for at least 6 months, but considering the bleeding risk, I may have, consider bleeding risk 6 months. If it was not a higher bleeding risk, maybe I would continue for 12 months. The fact that I use 2 stents on a bifurcation is certainly a good reason to use DAPT, and I would not object if someone would give ticagrelor instead of clopidogrel. But if I am confident that the result is good and I did not implant long stents, I think clopidogrel should be sufficient.
Are there any comments or questions from the audience? Don't be shy, don't be silent. We want to hear your opinion, so please speak up. Meanwhile, Thomas, a question for you. So Antonio is telling us that if a patient is high bleeding risk, he would favor clopidogrel, so the relatively weak P2A12 inhibitor, because of the bleeding risk. I would not do that. How would you react to this scenario?
Yeah, I think I will do more or less what Pascal did, but I will do it differently. Meaning I will try to have optimal treatment for the early period, because we know that especially the risk of stent thrombosis, up to 80% of stent thrombosis will occur within the first months after PCI. So I will probably give, exactly as you did, aspirin and ticagrelor for the first months. And after, I will do another de-escalation strategy, and I will probably switch to clopidogrel and give aspirin and clopidogrel up to 6 months. So it's more or less the same strategy, but you choose ticagrelor as monotherapy, while I will probably do less potent DAPT. But the philosophy of the strategy is the same, I think.
Bernard,
but
yes,
don't you
go on.
think you would give ticagrelor to
Yes.
this patient?
So,
But,
good point, because I did not clarify that. So my reaction to the high bleeding risk is not to down-escalate the potency of the P2A12 inhibitor, but to reduce the length of antiplatelet therapy. So I would definitely give aspirin ticagrelor or aspirin prasugrel. I have nothing in favor of one or the other. For me, it's the same. I know that they are only better than clopidogrel in this setting. That's the only thing I know. And then, of course, the question is for how long. It would not be 1 year, that's for sure. Then we can discuss whether it's 1 month, 2 months, 3 months. And then how do you continue? Do you stop the P2A12 inhibitor and you leave the patient on aspirin monotherapy, or you do vice versa? Here, in this experimental treatment strategy of this study, that was aspirin was stopped and the patient was continuing on ticagrelor, but probably I would do the same exercise in my practice, so probably stopping aspirin at a certain point and leaving the P2A12 inhibitor alone.
Let us not forget this patient, his initial presentation was a STEMI.
Right.
Yeah.
Right. Yes, absolutely. If it would be a stable patient, I would not give ticagrelor or prasugrel. There would be no discussion, would be clopidogrel. Bernard, do you use risk scores in your practice, or you rely on your experience? Honest answer, otherwise we will not ask that question.
No, I use the bleeding risk score in routine practice, but not really ischemic thrombotic risk score in my practice. I must rely on my experience. To be honest, in this case, I think it's a nice example of drug-device interaction, and I think that we should really maximize the role of provisional stenting approach in this lesion to try to minimize the role of long duration of ticagrelor, which is, of course, higher bleeding risk in this kind of patient. So I think I would try to do a provisional stenting, high threshold for a second stent. And if I succeed, I will go to clopidogrel. If I fail, putting 2 stents, I will go to tica.
I would agree with you, but looking at the image of the circumflex bifurcation, I would probably approach that directly with the bifurcation stenting technique. Look at the image. My reaction would be I will never be able to get a perfect result in this side branch unless I'm going to stent it up front. And if I don't do it, I will have to end up doing it at the end. So I immediately would start with the bifurcation stenting technique. Antonio, you are really the person that has to...
I'm more afraid of the bleeding. Unless I've done 5 stents, something really extreme, I try to minimize antiplatelet therapy to what is needed. I do IVUS to make sure that the result is nice, but I don't like to depend too much on DAPT. So, of course, if I implant a bioresorbable, very thick strut, but with current DES, very thin struts, implanted very well, with TIMI3 flow at the end, I mean, the risk of thrombosis is below 1%. So, unless, I mean, why do you subject the patient to the bleeding? Bleeding is something that I want to minimize.
Well, I think the point of Antonio is well taken. We were discussing before the possible role of FDI in guiding the APT duration or discontinuation. But in fact, what we did not discuss is the role of imaging of the eye, of course, as well, but perhaps even OCT or IVUS, whatever, just to judge how well the procedure was performed, how much malpositioning you have, how much underexpansion you may have. Once you have all these variables under control, we know that the requirement for the APT is actually...
But why don't you want to have this variable under control?
I used the Colombo technique in this patient. High pressure. The highest pressure that I could give to this patient. So this was really double balloon technique, full-blown pressure.
But the result was exceptional. I don't want to criticize the case, but only saying that sometimes angiographically everything looks perfect. If you dare to put an imaging technique, you will find some surprises. So I think with that said, it's time for us to move forward. Thank you very much, Pascal. It's now the time for the third case that will be delivered and discussed by Thomas Cuisset. Should we go beyond necessary, case 3, and we look forward to actually hear what you mean by this.
Yeah, thank you. Thank you, Marco. Thanks again for the kind invitation, just my disclosure. So indeed, the idea was to discuss DAPT challenges in complex clinical scenario. So I just want to discuss with you this case of a male, 62 years old, with new onset of angina, which was CCS between 2 and 3. He has significant prior medical history, is diabetic, active smoking, and he has also chronic alcohol abuse. As medication is not taking any antiplatelet drug before, just drugs for the diabetes. And according to the family, which is important before doing PCI and choosing any DAPT strategy, the family say that he has really irregular adherence. On the echo, he has good LV systolic function, 65, with no significant valvular disease. But on the stress, we have, let's say, limited abnormalities in the inferior wall with significant ST changes. On the laboratory, he had a good hemoglobin, but he has thrombocytopenia of 120,000. He has no significant coagulation disorder, let's say good kidney function, and moderate liver abnormalities. So the patient was sent to the cath lab, and on the left coronary system there was some atheroma, but no significant lesion on both the LAD and the circ. And we had what we can call angiographically a significant lesion of the mid-right coronary artery. So at this stage, just to summarize the case, we have a patient with chronic coronary artery disease. He has some specificity because it's alcoholic patient with already thrombocytopenia. He has stable angina with prior documentation of ischemia on the stress echo with both inferior ischemia and also significant ST changes. And he has what we can say 60 to 70% stenosis of the right. So in this patient, what should be the next step and what should be the option for revascularization? The first one could be to decide that we should not do PCI, but just try first optimal medical treatment. I know we are in Europe here, but we can discuss this strategy because in this patient, bleeding might also harm, even if it can provide benefit.
Thomas, can we stop here for a moment and then poll the audience and see what the audience would do in this case? Would they do a PCI or would they go for optical medical therapy?
So we will do medical treatment in this case, just say to avoid PCI.
Hands?
Is there hands? Yeah.
Well, we have an alcoholic patient, question about the adherence.
We have 10 to 15 people. We will not do PCI in the room. 10?
And we asked optical medical therapy, I thought. So how many hands again? 30. Okay, who would do PCI? Okay, that's a little bit more than majority. Okay, good. Let's go to the next.
Yeah, and because of the risk associated with PCI, we can also discuss whether we need one more argument and should we confirm the stress echo with IFR or with non-invasive functional assessment or invasive functional assessment can also be an option in this case. So to do no PCI here, but just optimal medical treatment in this patient, the answer is no. According to what we did for this patient, the reason were indeed the risk of bleeding and the risk of non-adherence to DAPT in this very particular patient, but still we have symptom and prior documentation of ischemia. So for this reason, we decided to proceed with PCI. What about the use of FFR in this right coronary artery? Again, I think we should not overuse FFR if we have symptom, documented ischemia in patient with single vessel disease, because we might end up with a situation with positive stress test, negative FFR, and after it's very difficult to decide. So I think FFR is a very good tool to be used in the cath lab, but probably not overused in such clinical situation. So finally, the decision was to do PCI of the right, again, because patient is symptomatic and he has significant ischemia. And also because today we can treat these high bleeding risk patients with new generation DES, which will make possible the use of short or even very short DAPT duration. But I think that definitely 10 years ago, to treat the same patient with the first generation DES was really more challenging. So now we've decided after the coronary angio that we will do PCI of the right. So again, we have different options. First one is to do ad hoc PCI with loading dose of clopidogrel just after PCI and to discharge as discharge therapy to have aspirin and clopidogrel, or to do ad hoc PCI and to give loading dose of ticagrelor after the PCI and to keep the same DAPT for the discharge therapy, or to take time to discuss with the patient, with the family, and to do stage PCI with loading dose of clopidogrel the day before PCI and keep this one for discharge, or stage PCI with more potent P2Y12 inhibitors. So I think that's the option which are now on the table and we can discuss with the panel and also with the room.
Okay, good. So we have 4 options. We would go for option 1. 10 people, a little bit more. Okay, 20. Option 2, minority, 5. Option 3, a little bit more, 5 between 5 and 10, and 4 staged. Also, okay. So no clear preference. Maybe one, the most.
Yeah. So Pascal, you say 4. So it's stage and ticagrelor.
Yes. The reasons for that is you demonstrated that this patient is alcoholic, has liver disease, and we know that clopidogrel would be metabolized by the liver. So I would try to avoid this, and I would try to use a P2Y12 inhibitor that is not acting to the liver, but major is bypassing the liver. So that's the reason why.
That's an interesting comment. I don't think no one has ever investigated whether a patient with liver disease or liver cirrhosis actually have lower capability of activating clopidogrel. I even never thought about that myself. But what speaks against this strategy, which is very innovative off-label, is also the fact that this patient is relatively high bleeding risk. So he has established liver cirrhosis, thrombocytopenia around the low range. You may say, well, it's true, but they're not really below the cutoff point for bleeding. But I would probably be very careful in giving ticagrelor to this patient, or even prasugrel, because I would be more concerned about the bleeding. It's off-label, it's stable CD. I would really give aspirin and clopidogrel and hope for the best. Peter?
Yeah. It's recent onset angina. Maybe you can discuss how stable or unstable it is. But looking at the lesion, I think it's quite stable, and I would also go for clopidogrel. Yeah. Another question would be, is this a kind of a scenario where you would also like to do some platelet function testing to check your adherence of patients? Is that also an option? Is that we are discussing? If you had the option of platelet function testing in your cath lab, would you, for instance, go for stage 4, see how well the patient is adhere to his medication before you put in the stent? Table for the discussion for the panel.
early after the intervention, so the odds that this patient would not be adherent at that time already is rather low. So the non-adherence will appear later on when the patient is out of the medical attention and there is no reassessment, because on adherence, every reassessment will increase adherence. So if the patient is left alone for 6 months, that's why the problems will come up.
But Peter, probably if we try to do that, we need to do stage PCI and to tell the patient to take the drug for 1 week. And when he's coming back for the PCI, then we should test it just before PCI. Okay. And if we see that he didn't take the drug, then we have to optimize probably the education. But to do it ad hoc, I think it's too late, because we will check the adherence with platelet function test after putting the stent, which might be too late in this kind of patient. So strategy decide in this case, but I fully agree that we could do stage PCI to take time to explain to the patient, to the family, that he will have to take medication. We thought about the bleeding risk, so we decided not to give ticagrelor in this patient, but just to give 600 milligrams of clopidogrel. So we did it ad hoc because according to the lesion, it was not the ugly bifurcation that we've just seen during the case of Pascal, but it was, even if difficult to say that there is a simple elective PCI, but at least a priori it didn't look that risky and difficult. So we did it ad hoc. And for clopidogrel, also because of the lesion, but also because we don't have any evidence in such stable patient with low-risk PCI, we decided to keep clopidogrel, especially in this patient who has, by definition, due to the liver disease, a high risk of bleeding. So we didn't do any invasive functional assessment for the lesion of the right, but we just treat the right, which was a straightforward PCI with direct stenting and a 2.7515 Ultimaster stent. The patient had clopidogrel 600 milligrams after, with a good angiographic result. So the next question, as discharge, when I say a priori, because we don't know what will happen next, so we have to put on the file when we discharge the patient the a priori DAPT duration. And in this 62 years old male with stable CAD, alcoholic and thrombocytopenia with single vessel disease and new generation drug-eluting stent, should we go for 1 month, 3 months, 6 months, or longer?
Beautiful. I think let's poll this again. Who would go for 1 month DAPT in this specific patient? 10 at max. Who would go for 3 months? More for the majority. 30, 40 maybe. 6 months or longer? 6 months. Okay. What would the panel do, Antonio? If we may start with you.
You can go for 3 or 6 months, but whatever you decide is going to be the patient is going to decide. So this type of patients, most of the time they stop everything after 1 week, both aspirin and. That's in my experience.
But then again, would you treat this patient? Would you have treated this patient?
I would not. I kept silent. I would not object if someone would not stent this patient. Let's put it like that. I may stent, but I would not consider wrong not to stent. Because it's single lesion, you can increase medical therapy, and if he drinks a little bit more, the pain will be gone.
Okay, and considering you have all the stents available on the shelf, even the polymer-free, the DCS or bare metal, even maybe, perhaps. What kind of stent would you implant? Biodegradable polymer, durable polymer, drug-coated polymer-free, drug-coated stent.
Oh, you mean?
Yeah.
A new generation, any new generation stent You may make a point to implant a polymer-free. If you really want to be puristic, you can implant a polymer-free, or can even consider implanting a bare metal stent. Why not? Is a single lesion, short, 3 millimeter. The risk of restenosis, if it's 15%, 20%. So it's not a bad idea to implant a bare metal stent. But I think if you want to be puristic, according to the data available, maybe you should implant a biofreedom polymer-free, but bare metal stent would be fine, and maybe in a couple of years we can have data to implant some new generation stent.
Beautiful. And Bernard?
To be honest, I never use polymer-free DS, so I won't use in this case. I certainly won't go to a BMS, because I think if we go to BMS, it's better not to treat this patient, because doing a second intervention in this patient is probably a difficult thing, particularly considering the adherence to treatment and the adherence to medical follow-up. So I would use a stent with a quick coverage, and I think we have shown in Discovery 123 that Ultimaster is certainly one of them. I think it's a nice approach, and I would use a 3-month treatment and try to have a follow-up of this patient at 1 month if it's possible, just to convince him to continue treatment.
But Bernard, why would you, I kind of agree, but why would you be so strong against bare metal stent? I mean, we have been using bare metal stent in these lesions. Even if you do angiographic follow-up, a short lesion, very thin struts, I think the risk of restenosis is less than 20%. So it's very low.
I think the main message we got from Leaders 3 trial is there is no role for BMS in any type of lesion. And when you go to the subgroup of simple lesion in Leaders 3, you can see that there is no interaction between complexity of the lesion and the benefit of polymer-free versus BMS. So I think there is no role for BMS in practice in 2018. I agree we can treat this patient with BMS. We did it in the past. We also did it in the past without any stent.
I mean, Marco, what do you think? I mean, do we really have the scientific evidence to state that there is no role for BMS in May 2018?
If you ask me directly, I was trying to be silent.
Not
the answer
your
would be
present
yes.
Not
Not
your
yes,
present
Antonio.
impression.
Yes, yes, we have the evidence, I think. The only study which would play against that will be Norstent. I can disclose already that we have been good enough in convincing the Norstent investigators to share their database with us. So we are actually coming up with the individual patient data meta-analysis, including over 30,000 patients being randomly allocated to bare metal stent, thin strut bare metal stent versus second generation, newer generation DS. I don't want to disclose the results, but I would say that the meta-analysis, even including Norstent, is clearly speaking towards the fact that bare metal stent should disappear from our cath lab. And in fact, in Bern, they are not even available.
I'm not surprised about those results, because in the last 5 years history of PCI, bare metal stent have been used in the worst patients. And I bet how can you compensate for all the bad variables where they've used bare metal stent, in the patient actively bleeding, in the patient who is taking no medications at all. I mean, the worst of the worst is the patient who gets bare metal stent. So I'm not so sure that those results are really, I like to think that way, but I'm not so sure.
Well, speaking about
But
randomized
I think we
study,
should
though.
move on. Let's not
Right.
spend time on bare metal stents.
No, please.
Okay.
So in this case, 1 month, the answer was no, mainly because we don't have evidence for 1 month today as default strategy. So we've already mentioned the master DAPT study ongoing. And also because it's true, it's high bleeding risk patient, but I don't think it's a very high bleeding risk patient requiring as short DAPT as 1 month, like we could have in patient with anticoagulation, very elderly patient, or patient with prior or active bleeding. So we say that 3 months seems to be a good compromise in this case with new generation DES, while 6 months was too long in this patient who has clear risk of both bleeding and non-adherence. So the decision at discharge was to go for 3 months. So mainly because this patient will be defined as a patient with a mild thrombocytopenia between 100 and 150,000. And in this paper, they say that the bleeding prevention in this kind of high-risk patient with thrombocytopenia should be done by using PPI in all these patients, avoid 2B3 inhibitors, low dose of aspirin, and to shorten DAPT duration after new generation DS to 1 or 3 months. Of course, to use the radial approach and the new generation DS. So that's what we did in this case. We use Ultimaster with 3 months DAPT, which was the strategy decided at discharge. For the risk of non-adherence, we optimized the education of both the patient and the family. We had regular contact also with the general practitioner of the patient. And we use quickly a fixed dose combination of aspirin and clopidogrel because we know that if the patient has less pill to take, he will have a higher adherence rate. And of course, to shorten the duration of treatment will make everything easier. But as it has been said in the panel, the patient will often decide it for us. And in this case, 6 weeks after PCI, the patient was drunk and he arrived in the emergency department for trauma with minor bleeding, which can be defined as BARC2 bleeding complication, and also describe, since discharge, skin hematoma, meaning that it's a good sign that he probably took the DAPT. That's the good part. But still he had BARC1 bleeding since hospital discharge. So what should we do now in this patient? To keep DAPT up to 3 months, to stop aspirin, clopidogrel, to stop both. We are 6 weeks after PCI. Or again, same discussion, to use platelet function test to decide which ones should be stopped in this patient.
Okay, let's poll once more. Well, who is going to keep DAPT with this patient? Only BARC2. Okay, 5, no, 10 patients. The 10 doctors in the audience. Who will stop aspirin from those? Okay, not so 10 as well. Who will stop clopidogrel? 5 or 6. Who will stop both? Nobody. Okay. Who is using? No. Well, if you had platelet testing available, who would you do it to check your adherence? If you had it available, there's not so much.
Okay,
people.
So 6 months after new generation drug-eluting stent, patient with bleeding and clear high risk of bleeding. So we decide to keep it for 3 months. At this stage, for this patient, we know that the risk of adherence will be even higher due to the bleeding complication. So to stop aspirin without platelet function test could be a good option. It could be, again, defined as a compromise in this specific case. It's probably the same thing to stop clopidogrel. So I think both options are valid in this case. And to stop both, I think at 6 weeks, we still have a risk of stent thrombosis and secondary prevention is needed for this patient. So we had 2 options. In this case, I decided to stop clopidogrel and to keep aspirin as a single antiplatelet therapy, but I think both options are valid. So just to summarize the key learning of the case, the new drug-eluting stent with short DAPT allow easier management of really challenging patients and mainly patients with high bleeding risk. Then the DAPT duration should be tailored in each individual patient based on patient, the stent, but also the complexity of the PCI. But the DAPT strategy we decide just after putting the stent are always dynamic decisions which should be adjusted based on outcome and drug tolerance of the patient. Thank you.
Thank you very much, Thomas. You did a great job in presenting the case, also summarizing the case, so I will be lazy and not making any key learnings. They're already in front of me since we are running slightly late, and it's my privilege to call upon Antonio. Antonio Colombo will be present the last, but of course not least, case number 4, when number of stents and month of DAPT should not match. It's a bare metal stent case. Antonio will be a DS case.
Thank you very much. I'm going to start. This is a very old slide, but really emphasizes the fact that this tool, even if you make this leg of titanium, if you make this leg of paper, is not going to stand up. So the leg of titanium is the one made with aspirin, ticagrelor, and maybe even prasugrel. This leg made of paper is the leg made with a stent pool implanted. So I think you need a balance between the three, and the other leg is a distal flow, with really nothing much we can do. But my point, this is a work of triad, of course, is nothing new. My point is that it's not a good idea to compensate for some weakness by increasing the weakness of the other. We always do, but optimally we should have the three strengths well distributed in order to have a stable long-term result. This is in theory. We never do this, but we have to try, at least conceptually, to optimize all the three variables. This is another, it's a little bit more recent than Virchow, is 98. This is the first registry where we did bare metal stent implantation with a single agent, with only aspirin. No loading dose of anything, just aspirin, and the thrombosis was 1.3%, so was really extremely low, which is something that you will never even consider to put a stent and give only aspirin. Only 161 patients, 2 stent thrombosis in the first week after stenting. So I think it tells you that is not the answer, but implanting a stent well helps. So, and this meta-analysis, that's enough for the theoretical slides, of IVUS versus angio, and you see that the stent thrombosis is in favor when you do IVUS versus angio in many studies, randomized contemporary one. Nevertheless, we still don't do any routine or not even close to routine IVUS. So the take-home message of this introductory slide is that for the patient with high bleeding risk, shorter duration of PCI is appropriate. In this context, current generation DS with more favorable property for early endothelization, including thinner struts, higher biocompatible or reasonable or bioresorbable polymer, may allow shorter duration of DAPT. We should follow the optimal implantation technique to achieve the best possible result, even with the most reliable device and even with the best antiplatelet therapy. So this is the other element to stress. So now let's go to this case. This is a patient referred to us by vascular surgery. He has a thoracoabdominal aortic aneurysm, large size, no prior history of bleeding, standard risk factor for coronary artery disease, nothing remarkable in the laboratory data, good reasonable ejection fraction, and he has to undergo an operation. And first of all, would you send this patient to a preoperative coronary angiography? Who will ask a preoperative coronary angiography? He has no angina, nothing, Can you raise your hand? Okay, who will not ask a perioperative angiography? What about the panel?
So my honest answer would be, if you ask me, I would not. But if you ask what is practice in Bern, they would absolutely send this patient to angio before surgery. No way you can send this patient to surgery without angiography.
Okay, so let's continue, because that's what was done, and they will strongly complain. They will go to the director of the hospital if I refuse to do angiography on this patient. So this is the angiogram on this patient. Maybe a critical lesion in the right, not dramatic. I bet if you do FFR, maybe negative. And there is a more critical lesion on the circumflex. I think this is clear. And there is a total occlusion of the LAD. So this patient has to undergo surgery, not absolutely urgent, but quite to be done before the summertime. What would you do? Would you treat these lesions or not? First question.
Right. So
who would treat the lesion?
So by raise of hands, who would treat something here? Okay, so I would say the vast majority would intervene upon. The question is, who would you treat this chronic total occlusion of the LAD by raise of hands? Few. Who would treat this circumflex? Who would treat the RCA? So I guess the majority would actually tackle the circumflex. And what would you leave this as a true lesion untreated, right? And would you call this patient back after surgery, or would you just leave the patient alone after surgery? So who would actually call this patient back after surgery for stage PCI and try to achieve a complete revascularization? Who would not? Okay, there are more.
The question.
So it's a real mix of. I tell you what I would do.
Right. Let's wait, because we have a question. So now that the voice of the public is being said, I would like to hear that.
Hi. Thanks for the controversial case, Colombo. It's not actually a question, but rather a comment. There isn't any evidence that I'm personally aware of for patients undergoing non-cardiac surgery to have routine coronary angiography in the complete absence of symptoms. So in our institution, this patient would not have come to the cath lab unless they have prognostic ischemia on functional imaging and unstable anginal symptoms. That's point one. Point two, these patients are routinely treated with endovascular stenting, and perhaps under a spinal or even local in our institution. So that precludes the need for general anesthetic and extensive surgery, etc. Assuming the patient is having vascular surgery and the GA, in the complete absence of symptoms, I think we started in the wrong place. Now we have established the patient has severe coronary artery disease, in a slightly difficult situation. Perhaps functional imaging assessment is important. You need to understand what the LV function is, what is happening in the LAD territory, whether it's completely dead, infarcted, or otherwise, before you then plan your revascularization. And if you offer revascularization, you should not go for the ocular stenotic easy option, stent the circ, stent the right, and get on with surgery. Because who tells you that you have completely eliminated this patient's risk for general anesthetic by just treating spot and stenting the straightforward lesions?
So I personally agree with you 100%. The first statement I put forward is I would not make an angiogram in this patient, but put yourself in the shoes of Antonio. I don't think he would have done this angiogram either. Did I understand you correctly? This patient was referred to you.
You know, I think there is no evidence to support one way or the other. This problem really has not been investigated. So I mean, the more we do these angiograms, now we routinely have to do angiograms, I I'm not uneasy to do the angiogram, honestly, because sometimes we see patients operated by vascular surgeons that have an MI after surgery or during surgery. So I'm not so sure that, I mean, you have a good point, but I think the data to support is more lacking, is not in favor. We don't, this problem has not been investigated. We are a little bit late, so we need to move. I tell you what I would do. I would do an angiogram without making a fuss. If the surgeon don't do it, I may not do it, but if he asks me, I will do it, and I would stent the circumflex. That's it, nothing else. But this was not what was done. The operator reopened the LAD because he said large territory, which is fine. He was very skilled. He put stents on the LAD. He treated the circ. Let's move quickly. So standard good result. So I mean nothing wrong. Total number of stents in the circ. He has 2 stents and about 3 stents on the LAD. And he didn't bother to do any FFR on the right coronary. He placed 2 stents in the right coronary, well dilated, with an excellent result. So this patient had about 5, 8, 7 stents. And then he has to undergo surgery. When would you suggest, first of all, I don't think we have to answer the question, would you give DAPT? Of course, yes. Would you give ticagrelor? I don't think you need to give ticagrelor. He's a stable patient. For how long would you give DAPT? Minimum 3 months. The surgeon can wait 3 months to operate, or would you give it 6 months or 1 year? Who will give for 3 months and suggest surgery?
We do that.
Okay.
3 months is a good compromise.
Anybody will give 6 months and suggest surgery? Okay, so we go in between 6 and 3 months. I don't know if this was a good choice, but there's no question that going to surgery with a 3 vessel open is not a bad idea. So if they are well endothelialized after 3, 4, 5 months, I don't think it's a bad idea. So total number of stents, DAPT, aspirin, and for 1 month they gave of the second PCI. After 1 month DAPT, both aspirin were stopped. Cardiac surgery for thoracoabdominal was performed without DAPT. I would not really suggest this approach, but this is what was done. After successful operation, only clopidogrel was restarted, and 1 week after the operation, patient was discharged with any in-hospital thrombotic or bleeding complication. So I don't think, but you know, vascular surgeons don't like to have bleeding, and even if we suggest them not to stop, they do what they want. So that's something to keep in consideration. So retrospectively, knowing what the vascular surgeon would have done, despite your recommendation, I don't know if all this approach was appropriate. I was guided, is certainly good, because at least 1 leg of the stool is stable, but all of these, even if you don't do it, other people may do it. So I think it's something to be taken into consideration. I think we can stop here and have some additional comments.
So thank you very much, Antonia. It's always a very provocative and interesting case. I think there are many points that would probably need to be discussed. Acknowledge that we don't have too much time for doing so. But let me pick quickly your thinking and opinion on whether this patient should actually receive angiogram, yes or no, quickly, just by saying, yes, I agree, no, I don't disagree, I don't do this. Thomas, your position there.
I think in this patient I will have done non-invasive test and if positive angio, and I will probably not stop the aspirin for the surgery. I will keep on always aspirin and just negotiate with the with the vascular surgeon.
Provided this anatomy is in front of you and provided this patient is symptomatic, how would you handle this patient, this 3-vessel disease patient before surgery? Would you try to have a complete revascularization, then send to surgery? You would minimize stenting and then call the patient back?
Probably minimize and non-invasive test later for the other lesion.
Bernard, how would you do in Paris?
I think more or less the same. I will tackle only the circ, using, if possible, one stent in this bifurcation lesion. And I would go to 3 months DAPT doing that. But again, I think it's better if we can avoid systematic angiography in this kind of patient.
Pascal, quickly?
Exactly the same. Non-invasive stress testing, if possible, minimize.
Antonio, you said if I would have treated this patient, I would not reopen LAD. And honestly, I could not agree more with you, because if the concern is I want to avoid this patient having ischemic events during surgery, that's why this patient is...
Yeah, I would have treated the circumflex with a single stent, 3.5, and that's it. And not have done anything on the right, and I'm sure if you did the FFR on the right, it would have been negative. I like to do FFR when I don't want to treat a lesion and show that I'm not lazy.
I completely agree with you. And another comment with respect to stopping DPT everything after 1 month. This is a bit risky procedure. So you are always telling me, and I'm always listening to you, that to kill a patient you need to have 3 mistakes in a row. To me, the first mistake was making angiogram. The second mistake was actually stopping DPT. Good for the patient that the third mistake was not in place. Otherwise, probably this patient would not be alive. That is my comment.
You know, the important is to know the setting. You can tell the patient whatever you want, but if you know that the patient has no insurance, there's no money, even if you tell to take DAPT for 6 months, he will not take anything because you have to evaluate the setting. If you know that the patient is going to the vascular surgeon, even if you tell to continue aspirin, you know that the vascular surgeon never continue aspirin. So the fact that you wish something doesn't necessarily mean that what you wish will happen.
That's unfortunately very true. So with that said, thank you very much, Antonio, and I give the word to Peter for closing the session.
I think, what can I say? I think we can close the session. Thanks.
Oh, thank you very much. That was a quick one.